Alright guys, so I'm going to pretty much follow the handout here. Today we're going to try to get through spindle reflexes, cranial nerves, pupillary light reflexes, and probably into page 3 for eye movements. And then hopefully tomorrow we'll have a little extra time. We can do abnormal head posture and the associated eye position, VORs, and if we have enough time, we'll even get into center of mass, center of pressure stuff. Alright, so to start things out, let's take a look at a basic reflexive loop. We're going to have a receptor somewhere down here. We're going to have an afferent limb, which comes up into the dorsal horn. And then somewhere down here in the ventral horn, we're going to have the cell body. And then it's going to come out to an effector organ, somewhere peripheral. So if we're talking about muscle spindle reflexes, aka myotactic reflexes, we often look at it with a simple loop, kind of like a positive feedback loop, where it comes down and it activates the lower motor neuron, or the alpha motor neuron. So in this case, this would be a muscle spindle within the muscle belly, sensing stretch from something like a reflex hammer tapping on the tendon. Reflexively activate or increase the central integrated state of that homogeneous ventral horn to come back and give a little contraction at that homogeneous muscle. What we should realize, though, is that that's not the only thing that this reflex loop does. When it comes out, it has one branch coming here. It's associated with pain gating. Right, so it inhibits the nociceptive pathway. We have another branch somewhere in here. It'll come down. It'll excite an inhibitory interneuron. The synapses on the alpha motor neuron of the antagonistic muscle. So if this was the biceps, of course, this would be inhibiting the triceps. So it's not exactly bringing down the central integrative state of the ventral horn, even though it's an inhibitory mechanism, because it's still exciting that inhibitory interneuron. So we'll call that the biceps, triceps. In addition to this, we're going to have a cross-cord reflex. It comes over here, and it's essentially going to have the opposite effect contralaterally. So it's going to excite the triceps contralaterally. And it's going to have a branch that excites an inhibitory interneuron to the contralateral homogeneous muscle. Alright, so that's our simple reflex loop, a little more in depth. So as we can see, this is largely just a positive feedback loop. Alright, the more we fire this, we increase central integrated state, increase the health. The more we fire down to the muscle. The more we fire to the muscle, we increase the tone, we decrease the gain, we increase the sensitivity on all those receptors, and so we increase afferentation on all those receptors. So we have this positive loop that's going to sit here and increase the central integrated state. So what controls this mechanism is descending pathways or upper motor neurons, traveling in the lateral corticospinal tract or ventral corticospinal tracts, the cerebrospinal tract, etc. And so they're going to come down, and they're going to be the brake pedal for these mechanisms. They're just going to inhibit those. So in all our reflexes, it's important to understand the general patterns. So hyperreflexia means we have a loss of this braking mechanism. So we're going to have an upper motor neuron lesion. So it's going to be somewhere proximal to that ventral horn cell. Because even though this ventral horn cell is in the central nervous system, it's a lower motor neuron. Also with upper motor neuron lesions, we're going to see clonus and pathological reflexes. Hyperreflexia, it's going to be somewhere distal to the ventral horn cell. If we see absent reflexes from distal to proximal, we're thinking systemic disease such as diabetes. So as Josh was kind of touching in on, I think that was last Monday, if we recognize a pain pattern that's not dermatomal, it's not really a spinal nerve pattern, and we're suspecting sclerogenic pain referral, then we want to recognize which spinal level that's coming from. So if I have some diffuse pain in my right shoulder, I might be thinking, okay, I want to see if that's sclerogenic pain referral from the C5 vertebral level. So what's something I can do reflexively to increase the central negative state and the pain gating at the C5 segment, the segmental level? You guys know of any C5 reflexes? Biceps. All right. It's Halloween, so you get a piece of candy. You guys, yeah, look a little more perky now. I know you guys probably won't eat the candy, but you can throw it at someone later. What else can we do here? So, we have somatotopic organization in these lateral corticospinal tracts. Basically, we have the feet. I'll just try to draw a crappy picture. We got feet, legs, body, up to the hands, right? So first on the bus, first off. As we're descending, the hand's going to be coming off first, so it's going to jump off, and the feet lastly. So if we got cord compression coming from the lateral side, the first to be affected is going to be the feet, right? And what sits out here, as we've been talking about, the posterior spinal arteries. What's important though is what sits just lateral to them, which is a venous plexus. In people with hypertension or some other systemic diseases, sometimes we have an accumulation of blood in these venous structures. It's not actually the artery that's pressing on the cord. It's going to be the pooling in these venous structures. And oftentimes the first thing that they're going to hit is the lateral edge of that lateral corticospinal tract. So you might see, some upper motor neuron lesion patterns in the foot show up first. We might see clonus on or in forced dorsiflexion. We might see flexor withdrawal response. So if we cause pain to the bottom of the foot, we're going to see an exaggerated flexor withdrawal. And we might see, of course, just hyperreflexia in general. What's next is we also want to consider the somatotopic organization of the brain, right? The frontal, if we take a coronal section of the precentral gyrus, it's going to look something like this. And basically, how it looks is we have the feet down here centrally, and we have the legs, and the butt sits right about here on this apex, and then we got the body, the torso, and then the hands. The hands take up a huge spot. We got the head and face, and the tongue. I believe anterior cerebral artery sits about here, covers this area, and the middle cerebral artery covers the rest. So if we see a stroke of the anterior cerebral artery on the right side, where might we see hyperreflexia in the body? On the left side of the body, it's a terrible picture. On the left side of the body in the associated region, right? So when I was down in El Salvador last summer, we saw a lot of patients with some very manifested diseases and pathology. And one guy was carried into my table by his friend and laid on the table because he couldn't walk because he had bilateral hamstring spasm. His heels were up by his butt, both of them. And so I'm sitting here thinking about this, and I was fresh out of the spinal cord module, and so I figured it out pretty quickly. But thinking about the somatotopic organization, where do you guys think the lesion would have been if it involved the upper motor neuron lesion of both his hamstrings and nothing else? I didn't find any other real notable things on the exam. Midline where?
Right along the false cerebri.
Yeah. So I'm pretty sure this guy had a tumor right about here, a mid-sagittal meningioma, which are fairly common. This guy's gonna take all your candy. Might be a 2 candy question actually. So those are pretty common, and I told him to go to the hospital if that didn't go away real soon. It was 3 months that he was dealing with this. Okay. What's next? Cranial nerve reflexes. Christian, do we have a cranial nerve module coming up? Okay, that's 809. Okay. So what do I got? I'll just go through these quickly. I think repetition's good anyway. So the corneal reflex, aka the blink reflex, you basically take a piece of cotton or a tissue, we touch the cornea of the eye, the limbus, and we should see both a direct and a consensual blink response, right? And it should be fairly quick, within 0.1 seconds, I believe. So the afferent limb on that, of course, is going to be V1 of the trigeminal, and then the efferent is going to be cranial nerve 7. Okay, so what if we touch the right cornea and we see no reflex at all in either eye? What are we thinking? Afferent limb, yeah. What about, okay, I guess that's what about if we touch the right eye and we only see a response in the left eye? What are we thinking? Efferent, right side, cranial nerve 7. If we're thinking cranial nerve 7, what's a test that we could use to double check cranial nerve 7? We could have them make some facial expressions, wrinkle the forehead. We could put a tuning fork to the ear. We're going to have hyperreflexia because the stapedius muscle isn't being dampened. Alright, that can also be triggered by loud noises. Moving on to the pupillary light reflex, alright? So we're going to want to do direct and consensual, and just like the corneal reflex, we can pretty much easily come up with if it's an afferent or an efferent limb based on direct and consensual. But let's talk about rate de sommeil and fatigability in these pupillary reflexes. So if you have a pupil that reacts rapidly and then fatigues rapidly, what do you suspect? Yeah. So anytime we hear fatigue rapidly on Mondays, Wednesdays, and Thursdays in this room, we're thinking T&D, right? So we're thinking T&D at the Edinger West Wall nucleus or at the mesencephalon, and we're thinking, we're just putting it in our box of exam findings, but it could be one of the first things to show up on a hemisphericity. In this case, we probably want to activate that mesencephalon and test it again, see if it improved. If the pupil reacts quickly and it holds in constriction, it just holds and holds and holds, and it doesn't want to release, then we're thinking maybe a ramped up mesencephalon. All right, so what's constantly releasing dopamine into the mesencephalon to kind of modulate its central and gate state? What's constantly releasing dopamine into the mesencephalon? All right. How about a crunch?